Question 1. Wound healing physiology. Chronic wounds often fail to progress through the normal stages of wound healing. One of the primary reasons for this is the prolonged inflammatory phase. Which of the following factors is most likely to contribute to prolonged inflammation and delayed wound healing? A. Increased fibroblast proliferation and collagen deposition. B. High levels of matrix metalloproteinases, MMPs, degrading extracellular matrix. C. Early angiogenesis leading to excessive granulation tissue. D. Increased epithelial migration and rapid wound contraction. Answer: B. High levels of matrix metalloproteinases, MMPs, degrading extracellular matrix. Explanation: wound healing follows a sequential process: hemostasis, inflammation, proliferation, and remodeling. Chronic wounds often stall in the inflammatory phase due to excessive protease activity, particularly from matrix metalloproteinases, MMPs, which degrade collagen and extracellular matrix (ECM). This prevents NUT formation and delays wound closure. Option A is incorrect because fibroblast proliferation and collagen deposition are necessary for the proliferative phase and contribute to wound closure rather than delaying healing. Option C is incorrect because angiogenesis, while critical, does not necessarily lead to chronicity unless uncontrolled. Excessive granulation tissue can lead to hypertrophic scarring, but it is not the primary cause of chronic wounds. Option D is incorrect because increased epithelial migration and contraction accelerate wound healing rather than delaying it. Clinical guidelines suggest modulating MMP activity with specialized dressings, collagen-based or silver-impregnated, to promote healing in chronic wounds. Question 2. Scenario-based. Wound infection and microbiology. Mrs. Thompson, 72-year-old diabetic patient with venous stasis ulcer on her lower leg, has been undergoing standard wound care with appropriate debridement and moisture management. Over the past few days, a wound has developed increasing periwound erythema, malodor, and copious purulent exudate. She also reports low-grade fever and malaise. Based on these findings, what is the most appropriate next step in her wound management? A. Increase the frequency of standard dressing changes and observe for 48 hours. B. Initiate topical antiseptic treatment and avoid systemic antibiotics unless symptoms worsen. C. Perform wound culture and initiate broad-spectrum systemic antibiotics. D. Prescribe corticosteroids to reduce inflammation and erythema. Answer: C. Perform a wound culture and initiate broad-spectrum systemic antibiotics. Explanation: the presence of erythema, malodor, purulent exudate, fever, and systemic symptoms suggests the spreading wound infection, possibly evolving into cellulitis or sepsis. Immediate intervention is required. Option A is incorrect because delaying intervention for 48 hours increases the risk of worsening infection, particularly in an immunocompromised diabetic patient. Option B is incorrect because while topical antiseptics can help with local bacterial load, they are insufficient in systemic infection cases. Systemic antibiotics are needed to prevent deeper tissue involvement. Option D is incorrect because corticosteroids suppress the immune response and can exacerbate infection, delaying wound healing. Guidelines. The Infectious Diseases Society of America, IDSA, recommends obtaining a wound culture before initiating antibiotic therapy, but in cases of severe infection, empirical broad-spectrum antibiotics should be started immediately. Question 3. Compression therapy and edema management. A patient with chronic venous insufficiency (CNI) presents with a venous leg ulcer and significant lower extremity edema. Which of the following compression therapy strategies would be most appropriate for this patient? A. Use of short stretch bandages that provide high working pressure and low resting pressure. B. Application of tight long stretch bandages with sustained high pressure. C. Avoidance of compression therapy due to the presence of an open ulcer. D. Prescribing diuretics to reduce fluid retention as the primary treatment strategy. Answer: A. Use of short stretch bandages that provide high working pressure and low resting pressure. Explanation: compression therapy is the gold standard for venous ulcers and chronic venous insufficiency, but the type of compression matters. Short stretch bandages, e.g., under boots, provide high working pressure during activity and low resting pressure, making them ideal for reducing venous hypertension while allowing blood return during muscle contractions. Option B is incorrect because long stretch bandages provide constant high pressure even at rest, which can cause ischemia and discomfort, particularly in immobile patients. Option C is incorrect because compression is essential for venous ulcers, and not using compression can lead to worsening edema and delayed healing. Option D is incorrect because diuretics do not directly address venous hypertension and are not a first-line treatment for venous ulcers. Guidelines: the Wound Ostomy and Continence Nurses Society (WOCN), an international compression club, recommend compression therapy as the standard of care for VLUS provided arterial perfusion is adequate, assessed via ankle brachial index AB 0.8. Question 4. Topic: Wound infection and microbiology. A 65-year-old male with diabetes presents with a chronic non-healing foot ulcer that has persisted for over 6 months. The wound has increased exudate, a foul odor, and significant slough tissue despite multiple debridements. A swab culture reveals a polymicrobial infection with methicillin-resistant Staphylococcus aureus (MRA) and Pseudomonas aeruginosa. The patient on broad-spectrum antibiotics, but there is minimal improvement. Which of the following is the most appropriate next step in managing this wound? A. Continue broad-spectrum antibiotic therapy and monitor wound healing over the next 4 weeks. B. Initiate a combination of topical silver dressings and systemic antibiotics targeting MRSA and Pseudomonas aeruginosa. C. Perform a deep tissue biopsy for culture and sensitivity, followed by targeted antibiotic therapy based on results. D. Proceed with aggressive sharp debridement without changing antibiotic therapy. Answer: C. Perform a deep tissue biopsy for culture and sensitivity, followed by targeted antibiotic therapy based on results. Explanation: in cases of chronic, non-healing wounds with signs of infection, surface swab cultures are often unreliable due to contamination from colonizing flora. Instead, deep tissue biopsy is the gold standard for identifying the true infecting organisms and guiding targeted antimicrobial therapy. Answers: A. Simply continuing broad-spectrum antibiotics without confirming the specific bacterial load may lead to antibiotic resistance and further complications. B. While silver dressings can be beneficial for biofilm control, they do not replace the need for accurate pathogen identification and appropriate systemic antibiotic therapy. D. Aggressive debridement is necessary, but it must be accompanied by proper infection control, including precise antibiotic selection. Question 5. Topic: Compression therapy and edema management. A 72-year-old woman with a history of chronic venous insufficiency presents with a large venous ulcer on her left lower leg. The wound is surrounded by hemocytoin staining, moderate edema, and significant serous drainage. The API ankle brachial pressure index is measured at 0.65. The clinician considers initiating compression therapy. What is the most appropriate compression strategy for this patient? A. High compression multi-layer bandages for MHG applied continuously. B. Low compression therapy 20 MHG with frequent elevation of the limb. C. Ulnar boot application with moderate compression 2-5 3-year MHG. D. Pneumatic compression therapy without bandaging. Answer: B. Low compression therapy for MHG is contraindicated due to the risk of ischemia. Low compression therapy 0.8, as higher compression can cause ischemic damage in patients with arterial insufficiency. C. Ulnar boots provide moderate compression 2-5 3E MHG, which may still be too high given the arterial component of the disease. D. Pneumatic compression may be helpful, but without additional compression may not effectively manage venous return. Question 6. Scenario-based. Topic: Wound healing physiology. Mr. Reynolds, a 78-year-old male with a history of Copland malnutrition, undergoes a total knee replacement. After 2 weeks, he develops dehiscence at the surgical site with exposed subcutaneous tissue. His serum albumin is 2.8 grams to low, and he has significant muscle wasting. Which of the following interventions would be most effective in optimizing wound healing for this patient? A. Increase protein intake to 1.5 grams a day and provide vitamin supplementation. B. Prescribe systemic steroids to reduce inflammation and prevent further tissue breakdown. C. Apply an occlusive hydrocolloid dressing and monitor for infection. D. Initiate aggressive negative pressure wound therapy immediately. Answer: increase protein intake to 1.5 grams a day and provide vitamin supplementation. Explanation: malnutrition and protein deficiency are major risk factors for poor wound healing and dehiscence. Increasing protein intake 1.5 grams a day and supplementing vitamin, which enhances epithelialization and immune function, are essential for improving wound strength and closure. Incorrect answers. B. Systemic steroids impair wound healing, suppressing inflammatory responses and fibroblast activity. C. While hydrocolloid dressings maintain moisture balance, they do not address the underlying nutritional deficiency. D. To help promote healing, but it should only be initiated after nutritional optimization to ensure tissue integrity. Question 7. Topic: wound bed preparation and biofilm management. A 62-year-old female with chronic venous insufficiency presents with a recurrent venous ulcer on her medial lower leg. Despite consistent use of compression therapy and appropriate dressings, the wound continues to exhibit thick biofilm formation, moderate exudate, and delayed healing. A wound culture identifies the presence of Pseudomonas aeruginosa and Staphylococcus epidermidis. Which of the following is the most appropriate next step in managing this wound? Increase frequency of standard moist wound dressings and continue observation. B. Apply topical antiseptic solutions daily and initiate systemic antibiotics. C. Perform mechanical debridement with an antimicrobial dressing followed by pulsed lavage therapy. D. Use enzymatic debridement agents and avoid aggressive mechanical debridement to minimize tissue trauma. Answer. C. Perform mechanical debridement with an antimicrobial dressing followed by pulsed lavage therapy. Explanation. Chronic wounds with biofilm formation require aggressive debridement, sharp mechanical, or pulsed lavage therapy to disrupt microbial colonies and promote healing. Antimicrobial dressings, silver, iodine, or honey-based, help prevent biofilm reformation. Incorrect answers. A. Simply increasing moist dressings will not address biofilm-related infection. B. Systemic antibiotics are only warranted if there are systemic signs of infection. E. G. Fever increase B. Kunter. D. Enzymatic debridement is slow and not as effective as mechanical debridement in disrupting biofilm. Question 8. Topic: diabetic foot ulcers and offloading strategies. A 58-year-old male with type 2 diabetes and peripheral neuropathy presents with a non-healing plantar foot ulcer at the metatarsal head. There are no signs of infection or ischemia and the API is 1.0. The patient has been using a standard soft-soled shoe with frequent dressing changes. What is the best offloading strategy for this patient? A. Continuation of current footwear with weekly monitoring. B. Total contact casting (TCC) for complete offloading of the ulcer. C. Custom orthotic inserts to redistribute pressure. D. Bed rest to reduce weight-bearing forces. Answer. B. Total contact casting (TCC) for complete offloading of the ulcer. Explanation. Total contact casting (TCC) is the gold standard for offloading neuropathic diabetic foot ulcers located at high-pressure areas such as the metatarsal heads. Incorrect answers. A. Soft-soled shoes do not provide sufficient offloading for deep plantar ulcers. C. Custom orthotics help prevent ulcers, but TCC is superior for healing exit ulcers. D. Bed rest is not practical for long-term management and can lead to muscle atrophy and complications. Question 9. Topic: osteomyelitis in chronic wounds. A 67-year-old patient with a stage Roman Orescia ulcer on the sacrum develops persistent drainage and exposed bone. A propabone (PTB) test is positive and MRI confirms subacute osteomyelitis. The patient is hemodynamically stable with no signs of systemic infection. What is the best initial treatment approach? A. Start broad-spectrum Roman antibiotics and perform aggressive surgical debridement. B. Continue local wound care and monitor for progression of infection. C. Prescribe oral antibiotics for 6 weeks and apply antimicrobial dressings. D. Perform serial sharp debridement while using topical antibiotic therapy. Answer A. Start broad-spectrum Roman antibiotics and perform aggressive surgical debridement. Explanation. Osteomyelitis in chronic wounds requires a combination of Roman antibiotics and surgical debridement to remove infected bone. Incorrect answers. B. Monitoring without intervention can lead to systemic infection. C. Oral antibiotics alone are insufficient. Antibiotics are required for deep bone infections. D. While serial debridement can help, surgical intervention is typically required for deep osteomyelitis. Question 10. Topic: wound healing in immunocompromised patients. A 55-year-old patient with end-stage renal disease, ESSED, on hemodialysis presents with a surgical wound dehiscence post-arteriovenous AV fistula placement. The wound edges are fragile and there is minimal granulation tissue. Which of the following interventions is most critical for wound healing in this patient? A. Increasing caloric and protein intake. B. Using hydrocolloid dressings to maintain moisture. C. Initiating systemic steroid therapy to reduce inflammation. D. Applying compression wraps to reduce edema. Answer A. Increasing caloric and protein intake. Explanation. Patients with SID are at high risk for poor wound healing due to malnutrition, metabolic imbalances, and uremia. Correcting protein and calorie deficiencies is essential for fibroblast function and tissue repair. Incorrect answers. B. Hydrocolloid dressings may maintain moisture but do not address the underlying cause. C. Steroids impair wound healing and should be avoided unless necessary. Autoimmune conditions. D. Compression is useful for venous ulcers but is not the primary concern in SID-related wounds. Question 11. Topic: Hyperbaric oxygen therapy. HBOT in chronic wounds. A 70-year-old patient with a non-healing diabetic foot ulcer undergoes a transcutaneous oxygen measurement (ECPA), which is 30 mHg. The wound has no significant infection but has failed standard wound care for 3 months. Is this patient a candidate for hyperbaric oxygen therapy at HBOT? A. Yes, because ECPO 20 mHg is sufficient for healing. C. Yes, but only ECPO drops below 10 mHg. D. No, because HBOT is only recommended for infected wounds. Answer A. Yes, because ECPO 40 mHg suggests hypoxia and a poor healing environment. Explanation. HBOT is recommended for chronic non-healing diabetic ulcers where ECPO is 4 mHg, indicating tissue hypoxia. Incorrect answers. B. Healing is significantly impaired below 4 mHg. B. ECPO mHg suggests severe ischemia but is not a threshold for HBOT. D. HBOT benefits both infected and non-infected hypoxic wounds. Question 12. Topic: Pressure ulcer prevention and staging. A 78-year-old bedridden patient in a long-term care facility develops red, non-blanchable erythema over the sacral region. The skin is intact and there is no necrosis or slough. The nursing staff has been performing 2-hour repositioning, moisture management, and skin inspections. What is the correct stage of this pressure ulcer and what should be the next best step? A. Stage I pressure ulcer. Continue repositioning and implement pressure redistribution surfaces. B. Tigiomen 2 Escher ulcer. Start enzymatic debridement. C. Stadiomen Rescher ulcer. Begin aggressive wound care with negative pressure therapy. D. A suspected deep tissue injury (DTI). Refer for surgical evaluation. Answer A. Stage I pressure ulcer. Continue repositioning and implement pressure redistribution surfaces. Explanation. Stage I ulcers involve non-blanchable erythema over intact skin. Management includes pressure redistribution, frequent repositioning, moisture control, and proper nutrition. Incorrect answers. B. Stidiomen ulcers involve partial thickness skin loss with exposed dermis. C. Stagiomen ulcers involve full thickness skin loss, possible fat exposure. D. Deep tissue injuries present as purple maroon discoloration with underlying soft tissue damage. Question 13. Topic: Negative pressure wound therapy. Debut and indications and contraindications. A 45-year-old patient with a post-surgical abdominal wound dehiscence has moderate exudate but no exposed vital structures. The wound is clean, granulating, and non-infected. Is this patient a candidate for negative pressure wound therapy? Debut remotes granulation tissue formation and exudate control. No debuts are contraindicated due to the presence of exudate. C. Yes, but only if systemic antibiotics are initiated. D. In a debut only indicated for infected wounds. Answer A. SW remotes granulation tissue formation and exudate control. Explanation. A W accelerates wound healing by reducing exudate, promoting angiogenesis, and maintaining a moist environment. Incorrect answers. B. Exudate alone is not a contraindication for BC. Antibiotics are unnecessary unless systemic infection is present. DBs are limited to infected wounds. It is effective for clean, granulating. Question 14. Topic: Burn wound classification and management. A 30-year-old patient sustains a deep partial thickness burn on the anterior thigh from boiling water exposure. The wound is painful, moist, and has blisters. There is capillary refill present. What is the best initial wound management strategy? A. Debride all blisters. Apply silver sulfadiazine and cover with a non-adherent dressing. B. Leave blisters intact. Apply an occlusive hydrogel dressing and reevaluate in 72 hours. C. Apply enzymatic debridement agents and use compression therapy. D. Perform immediate skin grafting to prevent scarring. Answer A. Debride all blisters. Apply silver sulfadiazine and cover with A non-adherent dressing. Explanation. Deep partial thickness burns require debridement, infection control, and moisture balance. Incorrect answers. B. Intact blisters may be left in superficial burns but should be debrided in deeper burns. C. Enzymatic debridement is not first-line therapy for burns. D. Skin grafting is reserved for full-thickness burns. Question 15. Topic: venous versus arterial ulcers. A 65-year-old male with a history of hypertension and hyperlipidemia presents with a painful ulcer on the lateral ankle. The ulcer has punched-out borders, pale wound bed, and minimal exudate. The ankle brachial index ABI is 0.6. What is the most likely diagnosis and what is the most appropriate management? A. Venous ulcer. Apply compression therapy. B. Arterial ulcer. Initiate vascular evaluation and avoid compression. C. Neuropathic ulcer. Recommend offloading footwear. D. Pressure ulcer. Initiate. Answer. B. Arterial ulcer. Initiate vascular evaluation and avoid compression. Explanation. Arterial ulcers occur due to peripheral arterial disease pad and have punched-out borders with poor perfusion. Compression is contraindicated in arterial ulcers due to compromised blood flow. Incorrect answers. A. Compression therapy is appropriate for venous ulcers, not arterial ulcers. C. Neuropathic ulcers typically occur on weight-bearing areas. B is not the first-line treatment for arterial ulcers. Question 16. Topic: wound infection versus colonization. A 72-year-old female with a chronic pressure ulcer on her ischium has increased wound exudate, delayed healing, and mild erythema. Wound culture grows Pseudomonas aeruginosa and Staphylococcus aureus, but there is no systemic infection. What is the best interpretation of these findings? A. Wound infection. Initiate systemic antibiotics. B. Wound colonization. Continue local wound care. C. Sepsis. Initiate broad-spectrum Romanet antibiotics. D. Cellulitis. Prescribe oral antibiotics. Answer. B. Wound colonization. Continue local wound care. Explanation. Bacteria in a chronic wound without systemic size equals Keelan-Zayan, not infection. Incorrect answers. A. Systemic antibiotics are only needed for invasive infections. C. Sepsis requires fever, tachycardia, and hypotension, which are absent. D. Cellulitis presents with spreading erythema and systemic symptoms. Question 17. Topic: chronic wound management. A 45-year-old diabetic male presents with a chronic diabetic foot ulcer on the plantar aspect of his foot. The wound is 6 centimeters in diameter with necrotic tissue and has moderate exudate. The patient has poor glycemic control. What is the most appropriate first step in wound management? A. Debride the necrotic tissue, manage the wound with hydrocolloid dressing, and optimize glycemic control. B. Apply a silver-based dressing and begin hyperbaric oxygen therapy. C. Apply a wet-to-dry dressing and refer for surgical debridement. D. Start intravenous antibiotics and use a foam dressing to manage exudate. Answer A. Debride the necrotic tissue, manage the wound with hydrocolloid dressing, and optimize glycemic control. Explanation. Initial management of diabetic foot ulcers includes debridement of necrotic tissue and pressure offloading to promote healing. Incorrect answers. B. Silver-based dressings are used in infected wounds, but they should not be the first choice for a non-infected chronic wound. C. Wet-to-dry dressings are outdated as they caused trauma. Roman antibiotics are used for systemic infection, not for local wound management. Question 18. Topic: wound healing stages. A 35-year-old male presents with a fresh surgical wound that is 2 days old. The wound bed is red and moist with minimal exudate. He has no signs of infection and there is no necrotic tissue. Which phase of wound healing is the wound in, and what is the most important management focus? A. Inflammatory phase. Control infection and manage pain. B. Proliferative phase. Encourage granulation tissue formation and protect the wound from trauma. C. Maturation phase. Apply pressure to the wound to promote collagen formation. D. Hemostasis phase. Stop bleeding and apply a compressive dressing. Answer. B. Proliferative phase. Encourage granulation tissue formation and protect the wound from trauma. Explanation. The proliferative phase 2-4 days post-injury involves granulation tissue formation, and the main goal is to protect the wound while promoting healing. Incorrect answers. A. The inflammatory phase occurs immediately after injury and focuses on infection control and pain management. C. The maturation phase occurs after proliferative phase and involves collagen remodeling. D. The hemostasis phase is the initial response to wound where blood clotting occurs. Question 19. Topic: Wound infection identification. A 60-year-old female with a venous leg ulcer presents with increased pain, erythema, and purulent discharge. The wound culture grows methicillin-resistant Staphylococcus aureus MRSA. What is the most appropriate treatment for this infected wound? A. Begin oral antibiotics targeting MRA and continue compression therapy. B. Apply a silver-based dressing and use systemic corticosteroids to reduce inflammation. C. Debride the wound, apply a hydrocolloid dressing, and start a broad-spectrum antibiotic. D. Discontinue compression therapy and initiate Roman antibiotics immediately. Answer A. Begin oral antibiotics targeting MRSA and continue compression therapy. Explanation: MRSA infection in a venous leg ulcer requires oral antibiotics effective against MRSA. Compression therapy should be continued unless contraindicated. Incorrect answers. B. Silver-based dressings are helpful but not a substitute for systemic antibiotics. C. Broad-spectrum antibiotics should be used in cases of unidentified infection, not for known MRSA. The Roman antibiotics are generally reserved for severe infections or systemic symptoms. Question 20. Topic: Wound dressing selection. A 72-year-old male with a chronic dry wound on his elbow presents for wound care. The wound bed is necrotic with minimal exudate. Which dressing would be the most appropriate choice for this wound? A. Hydrocolloid dressing to maintain a moist environment and promote autolytic debridement. B. Alginate dressing to absorb excess exudate and maintain a moist wound bed. C. Foam dressing to provide cushioning and absorb exudate. D. Wet-dry dressing to facilitate mechanical debridement. Answer A. Hydrocolloid dressing to maintain a moist environment and promote autolytic debridement. Explanation: hydrocolloid dressings are ideal for necrotic wounds as they help maintain moisture and promote autolytic debridement. Incorrect answers. B. Alginate dressings are suited for wounds with moderate to heavy exudate. C. Foam dressings are used for wounds with heavy exudate and are not suitable for dry wounds. D. Wet dressings are outdated as they cause unnecessary trauma to healing tissue. Question 21. Topic: Chronic venous insufficiency management. A 56-year-old female with a history of chronic venous insufficiency presents with bilateral lower leg swelling and venous ulcers. She reports pain and itching at the ulcer sites. What is the most appropriate management for this patient? A. Initiate compression therapy and elevate the legs to reduce swelling. B. Prescribe corticosteroid ointment for the itching and elevate the legs. C. Recommend low-dose aspirin for blood thinning and use hydrocolloid dressings. D. Refer for surgical venous intervention and use foam dressings for ulcer management. Answer A. Initiate compression therapy and elevate the legs to reduce swelling. Explanation: compression therapy is the mainstay of treatment for venous ulcers and chronic venous insufficiency, helping to improve venous return and reduce edema. Incorrect answers. B. Corticosteroids are not indicated for venous ulcer management and could worsen healing. C. Low-dose aspirin is not an effective treatment for venous ulcers. D. Surgical intervention is reserved for severe cases and is not the first-line treatment. Question 22. Topic: Infected wound management. A 70-year-old male presents with a chronic ulcer that has become infected. The wound is red, swollen, and has thick yellow drainage. The patient is febrile. What is the most appropriate initial treatment for this infected wound? A. Start systemic antibiotics and apply a silver sulfadazine dressing. B. Clean the wound with iodine solution and apply a non-adherent dressing. C. Begin hyperbaric oxygen therapy and apply a hydrocolloid dressing. D. Debride the wound, culture the wound bed, and start oral antibiotics. Answer D. Debride the wound, culture the wound bed, and start oral antibiotics. Explanation: the first step in managing an infected wound is debridement, followed by wound culture to identify the causative organism. All antibiotics are appropriate based on the culture results. Incorrect answers. A. Silver sulfadazine is used in some cases, but is not the first-line option for infected chronic ulcers. B. Iodine solutions can be toxic to the wound bed and are not recommended for chronic wounds. C. Hyperbaric oxygen therapy is used for specific conditions like osteomyelitis, not for general wound infection management. Question 23. Topic: Pressure injury prevention. A 68-year-old immobile patient in a long-term care facility is at high risk for pressure injuries. The patient has limited mobility and no current wounds. What is the most appropriate preventive intervention? Implement a turning and repositioning schedule every 2 hours and use pressure-relieving devices. B. Use A hydrocolloid dressing on all bony prominences to prevent breakdown. C. Apply daily moisturizing lotions to prevent dry skin and improve elasticity. D. Begin a nutritional supplement regimen and monitor for edema. Answer. Implement a turning and repositioning schedule every 2 hours and use pressure relieving devices. Explanation. Repositioning every 2 hours and the use of pressure relieving devices are the most effective methods for preventing pressure injuries. Incorrect answers. B. Hydrocolloid dressings are used for treating wounds, not for preventing pressure injuries. C. Moisturizing lotions can prevent dry skin but do not address pressure injury prevention. D. Nutritional supplements are important but are secondary to repositioning and pressure redistribution. Question 24. Topic: biofilm and chronic wound infection. A 55-year-old female with a chronic wound is found to have a biofilm formation in the wound culture. The wound has not improved despite regular dressing changes and topical antibiotic therapy. What is the most appropriate next step in managing this wound? A. Consider advanced debridement methods such as sharp debridement or enzymatic debridement. B. Apply a silver-based dressing to disrupt the biofilm. C. Switch to oral antibiotics and increase dressing frequency. D. Begin hyperbaric oxygen therapy to promote healing. Answer A. Consider advanced debridement methods such as sharp debridement or enzymatic debridement. Explanation. Biofilm management requires advanced debridement techniques to remove the bacterial matrix. Sharp debridement or enzymatic debridement can effectively remove biofilm and promote healing. Incorrect answers. B. Silver dressings can help in infection control, but they do not directly disrupt biofilm. C. Oral antibiotics are active for chronic infections with biofilm. D. Hyperbaric oxygen therapy may help in specific cases, but is not the first step in biofilm management. Question 25. Topic: wound dressings for exudative wounds. A 50-year-old female presents with a moderately exudative wound on her leg. The wound has serous sanguineous drainage and sloughy tissue. Which dressing would be the most appropriate for managing this wound? A. Hydrocolloid dressing to manage moisture and provide a barrier. B. Alginate dressing to absorb excess exudate and promote healing. C. Foam dressing to absorb exudate and protect the wound. D. Gauze dressing to promote evaporation and reduce moisture. Answer B. Alginate dressing to absorb excess exudate and promote healing. Explanation. Alginate dressings are ideal for moderate to heavy exudate as they are highly absorbent and help promote wound healing by maintaining a moist environment. Incorrect answers. A. Hydrocolloid dressings are more suited for dry or necrotic wounds. C. Foam dressings are used for heavy exudate but are less absorbent than alginates in moderate exudate. D. Dressings are not ideal for moderate to heavy exudate as they can promote drying and trauma during removal. Question 26. Topic: diabetic foot ulcers management. A 45-year-old male with type 2 diabetes presents with a diabetic foot ulcer on the plantar surface of his foot. The wound is approximately 3 centimeters in diameter, shallow, and covered with yellowish slough. The patient has poor glycemic control and decreased peripheral circulation. The ulcer has been present for 3 weeks. What is the most appropriate first step in managing wound? A. Debride the slough, optimize blood glucose levels, and offload pressure on the foot. B. Begin hyperbaric oxygen therapy and apply a hydrocolloid dressing. C. Start systemic antibiotics for suspected infection and apply a foam dressing. D. Apply silver sulfadiazine cream and begin immediate surgical debridement. Answer A. Debride the slough, optimize blood glucose levels, and offload pressure on the foot. Explanation. The first step in managing diabetic foot ulcers is to debride necrotic tissue, optimize blood glucose control, and offload pressure on the wound to promote healing. Incorrect answers. B. Hyperbaric oxygen therapy and hydrocolloid dressings are typically used in cases of severe ischemia or infection, not as first-line therapy. C. Antibiotics are indicated when infection is present, but this wound shows no signs of infection at this stage. D. Silver sulfadiazine is typically used for infected wounds, not for simple slough removal. Question 27. Topic: pressure ulcer prevention and management. A 68-year-old bedbound patient in a long-term care facility is at risk of pressure ulcers. The patient has limited mobility and poor nutritional status. The caregiver is seeking guidance on how to prevent pressure ulcers. Which of the following is the most effective intervention for pressure ulcer prevention in this patient? A. Implement A turning and repositioning schedule every 2 hours. Use pressure-relieving devices and optimize nutrition. B. Apply hydrocolloid dressings to all bony prominences to prevent breakdown. C. Use a foam dressing to cover areas prone to pressure ulcers. D. Initiate a daily moisturizing regimen for the skin and recommend walking exercises. Answer A. Implement a turning and repositioning schedule every 2 hours, use pressure-relieving devices, and optimize nutrition. Explanation. The primary methods for pressure ulcer prevention are regular repositioning, use of pressure-relieving devices like specialized mattresses, and ensuring adequate nutrition to support skin integrity. Incorrect answers. B. Hydrocolloid dressings are for wound management, not prevention. C. Foam dressings are used for wounds with exudate, not for prevention. D. While moisturizing helps skin health, it does not directly prevent pressure ulcers. Question 28. Topic: Chronic wound assessment and treatment. A 62-year-old female with a history of venous insufficiency presents with a chronic leg ulcer that has been non-healing for 6 months. The wound is irregular in shape, located on the medial lower leg, and has moderate serous drainage. The surrounding skin is hyperpigmented, and there is no sign of infection. What is the best treatment strategy for this chronic venous leg ulcer? A. Begin compression therapy. Apply moist wound healing dressings and address underlying venous insufficiency. B. Apply silver-based dressings and begin systemic antibiotics to prevent infection. C. Start sharp debridement followed by the application of hydrocolloid dressings. D. Prescribe topical corticosteroids to reduce inflammation and recommend elevation of the legs. Answer A. Begin compression therapy. Apply moist wound healing dressings and address underlying venous insufficiency. Explanation. The mainstay treatment for venous leg ulcers is compression therapy to improve venous return along with moist wound healing dressings. Incorrect answers. B. Silver-based dressings are typically used for infected wounds, but this ulcer is not infected. C. Sharp debridement is useful in necrotic wounds, but this wound is chronic with signs of necrosis. D. Topical corticosteroids may worsen wound healing and are not recommended for venous ulcers. Question 29. Topic: Wound infection management. A 54-year-old male with a diabetic foot ulcer presents with signs of local infection, increased pain, erythema, and purulent drainage. The wound is 3 centimeters in diameter on the dorsum of the foot. The patient is febrile with a blood glucose level of 350 mgl. The wound culture reveals Staphylococcus aureus, including methicillin-resistant Staphylococcus aureus. MRSA. What is the most appropriate treatment for this infected wound? A. Start oral antibiotics specific to MRA and continue glycemic control with insulin. B. Initiate intravenous antibiotics, debride the wound, and apply foam dressings for exudate management. C. Begin topical silver sulfadazine and continue with wet to dry dressings. D. Apply iodine-based dressings, initiate oral antibiotics, and elevate the leg. Answer 8. Start oral antibiotics specific to MRA and continue glycemic control with insulin. Explanation. For local infections in diabetic foot ulcers, oral antibiotics targeting MRA should be started. Proper glycemic control is essential for wound healing. Incorrect answers. Roman antibiotics are typically reserved for severe infections with systemic symptoms, not for local infections in uncomplicated wounds. Silver sulfadazine is useful in more severe infections but is not the first choice for localized MRSA infections. D. Iodine-based dressings can be cytotoxic and should not be used routinely. Question 30. Topic: Biofilm in chronic wounds. A 60-year-old male with a chronic venous leg ulcer presents with minimal healing despite appropriate treatment. A wound culture reveals the presence of biofilm-forming bacteria, and the wound remains non-healing after 8 weeks of treatment. What is the most appropriate next step in managing this chronic wound with biofilm? A. Perform sharp debridement to remove biofilm and use enzymatic debridement. B. Apply a silver-based dressing and initiate hyperbaric oxygen therapy. C. Switch to oral antibiotics and increase dressing changes. D. Start moisture-attentive dressings and recommend daily leg elevation. Answer A. Perform sharp debridement to remove biofilm and use enzymatic debridement. Explanation. Biofilm formation in chronic wounds hinders healing, and the best approach is sharp debridement followed by enzymatic debridement to disrupt the biofilm. Incorrect answers. B. Silver-based dressings help with infection control but are ineffective in removing biofilm. C. Oral antibiotics will not effectively treat biofilm-related Wound moisture-attentive dressings help healing but do not address the underlying biofilm issue.